Dr. Ramou Njie.
I would like to start by thanking TAF and TAFCON for inviting me. Thank you, Mr. Chairman. And health is a very complex topic. I can only give an outline, if you like, and a few pointers as to what I think are the critical things that we have to do if we want to move from where we are. Health is wealth. This is an irrefutable fact. Health and poverty are closely linked, with cause and effect going in both directions. So sick people who cannot work are poorer, and poor people are more vulnerable to illnesses and disability. Now, children who are well are able to learn better. People who have good health are able to be more productive in terms of economic activity. They live longer, they pay more taxes. So health, definitely, the role of good health in economic development cannot be overemphasized. And I have to say that with all the best development plans in the world, if you don't have a healthy population, we're not going to go very far. So I want to start by looking at the current health system, which is in a state of flux. What kind of system do we have? Well, we have a health system whereby, apart from vaccination, where health workers go out and try to prevent infectious diseases, what we have is a kind of reactive health system whereby health workers stay in health facilities and people go when they're sick. And usually when they're very sick or when things are really advanced. And this model has been in existence, I guess, since independence. And in order to transform the health system, we need to change that paradigm. We really do. And to do that, we need to do two things. We need to emphasize prevention and make sure that active prevention of common illnesses are incorporated into our health plans. We need to decentralize the health system. The medical school has produced about 200 doctors. I think 90% of them are based at EFSTH in Banjul. So only less than 10% of them are in all the other hospitals. Now we have a three-tier system. There is one teaching hospital in Banjul, which is the Edward Francis Small Teaching Hospital. There are some 6 or 7 other hospitals in Kanifing, Bundung, Buyam, Farafenye, Bansang, and Basse. And then, Basse is a main health center. And then there are major health centers and some minor health centers. So often, when you go outside of this the coastal areas, there's very little access to healthcare. And although we have made progress, we have made progress in vaccinations, for example. So from 1970 to now, the number of children, and this is an indicator of how good your health system is, under 5 who are dying have fallen from over 300 per 100,000 to less than 70. And that is in part because of vaccination, because of malaria interventions, because of access to basic amenities like education, water, and sanitation. So those have helped, and the uptake of the vaccination. But when you look at the number of women that die in childbirth and pregnancy, yes, gains have been made. But according to the last WHO estimate, about 440 women in every 100,000 women are dying annually through childbirth. Now, that is a scandal. If you go anywhere in the world, anywhere else, well, certainly even in low and middle income countries, if a mother dies in pregnancy or childbirth, it causes an outcry. It causes an outcry and an investigation into why that's happening and measures to be put in place. And yet, women continue to die in childbirth. One of the reasons for that is lack of access to emergency care. I mean, if a woman in the eastern part of the country, in the Upper River region, for example, goes into obstructed labor and doesn't have an ambulance, she has to go by saret, often through very difficult roads, and then has to cross perhaps the river in an overcrowded ferry, if the ferry is there. And if it isn't, often the outcome is fatal. So this keeps happening. And really, to change this, we have to change the way we do things. And we do that by decentralizing. Now, we have several challenges. I don't think I need to tell this audience the challenges of the health system. One of the challenges is how do we actually sustain the gains that we have made in controlling communicable diseases. So infections don't kill as many people as they used to, but how do we ensure that we keep the vaccine coverage at a high level, especially for those infections that lead to cancer, like hepatitis B virus that leads to liver cancer, and human papillomavirus that leads to cervical cancer. These are the causative factors. And these are the two cancers that kill more Gambians prematurely than any other illnesses, really. How do we sustain those gains? How do we deal with the poor quality of care that we have in our health facilities? And by that, I mean the lack of diagnostics, the frequent stockouts of medication, inability or poorly managing the common ailments that we have. Because we're not just dealing with infectious diseases now, where we have what is known as a double burden of diseases. So things like hypertension, high blood pressure, diabetes, heart disease, cancers are on the increase. And we cannot really, no country in the world can treat their way out of these illnesses. We have to prevent them. Because when you I think about liver cancer, which I see every day, 2 or 3 new cases every day in my clinic in MRC. You can prevent infection with a vaccine that costs 20 cents a shot, and there are 3 shots that have to be given at birth, at 6 weeks, and 6 months. Compare that. And if someone is infected, you can even screen them and treat them to stop liver damage. Now compare that to what happens. People come with advanced cancer. They need surgery. They need chemotherapy. They need radiotherapy. We don't have a single oncologist in this country. So we can't deal with cancers as they are now. We have surgery, but we just do not have the resources to deal. Another problem that is coming up is that of kidney failure. And why do we have so much kidney failure in our society? Well, because we do not diagnose blood pressure, high blood pressure. We don't screen for it. We don't diagnose it. Diagnosis of diabetes is often missed or done at a late stage. So these two, not managed well, can lead to complications. And then we all know how expensive it is for the dialysis machines, for the consumables that we need in dialysis. So for these and other reasons, we have to change paradigm. So how do we respond to this? Well, I've said we have to change the health model. And really, to change the health model, we need to restructure the Ministry of Health. It needs to be restructured in line with this new vision. At the moment, at this current time, the ministry is organized in a way that hampers its ability to actually deliver its technical responsibilities. So we have about 16 or 17 directorates, 9 of them at the central level, others at the regional level. And these directorates actually almost function autonomously without much coordination from the center. And then this hampers the level of technical directives at the level of the ministry and what it gives to the regional centers. So I think that is going to need to be one key thing that has to be done if we want to move forward. But also to improve the technical capacity, to have somebody with high-level technical skills that can actually synthesize, analyze all the technical information from all the directorates and formulate policies. Somebody who has health system expertise, because your health system really is only as good as the people manning it. So if you have competent technical people, then there is no problem. But if we have people, low-skilled people, then you will not be able to deliver the optimum care that needs to happen. We need to make health a priority, and by we, I mean the government. All the African governments got together in 2001 and made a declaration in Abuja that said that they would put towards health 15% of their budgets. Now, I don't know, I haven't looked at the percentages, but I'm pretty sure that less than half of that was actually of the budget, the current budget was allocated to health. But it's not just what the government allocates, but to use more efficiently what the donor partners produce. So in other countries, like Uganda and other countries, all the donor partners' money is put into a central pool. So there's a health action, so it's a compact group that is made up of the ministry as well as all the donor agencies, and the money is put into one pot. And so this money is used depending on priorities, so that we focus the money where the needs are, rather than different arms of government, of the ministry doing different things. We need to set up, I feel, some at least 6 critical health action groups. And here I think those on the ground can work with the diaspora to move things forward. The first thing, I think the lowest hanging fruit, is the teaching hospital, because we have only one teaching hospital to serve 2 million people. Now, the teaching hospital has various challenges in terms of specialists and manpower. So the people who are supposed to train, we don't have that many specialists. I've told you that cancer is on the increase, but we don't have a single oncologist, we don't have a single neurologist, we don't have a single psychiatrist. I could go on and on. And we need to start training our doctors in country. Because when we send doctors outside, for each doctor, government has to pay about $60,000, and that excludes the airfare and and then whilst they're away, they're looking after other populations. But if we actually get help to bring in experts over a 7-year period to train our doctors in country, while training, they're actually serving the local population. It will save the government a lot of money, and I think it will lift the quality of care that we give to the local population. I think we need to talk about pharmaceuticals. I think we need to digitize the procurement system. It's been problematic for a long time. We have regular stockouts of essential medications. We need to deal with health financing and come up with a health financing model which will include, obviously, input from donor agencies that is sustainable in the long term. This is not beyond us. I think we can look at our population. We're a very small country. We're tiny. Less than 2 million people. So we should be able to come up with a health financing model, and diagnostics is another area. But ultimately, what I think we should all do, and by all, I mean all of us, the Ministry of Health, the private sector, civil society organizations, the diaspora, everyone, we should all mobilize, we should all advocate for health, we should all educate the general public so people know what is the basic standard, what is the basic level of healthcare that they deserve so that they can demand it of the health service providers, and call out if there is no, if it is not up to scratch. I think ultimately we deserve it. I think the Gambian people, the long-suffering Gambian people deserve better. We can and we should do better. Thank you, Mr. Chairman.